Welcome to another episode of Judgment Date. We have been doing these programs now for almost a year, and they were mainly designed, as it were, to assist people to get through the difficulties of the effects of COVID-19 pandemic. We've looked at the medical issues, we've looked at the legal issues, we've looked at the economic consequences. I had hoped by now that perhaps we would have got behind all of this, but the truth is that we aren't, and we're in the middle of a very, very significant second wave, and there are all sorts of questions that still arise. And I'm delighted to welcome and to thank him, because I know he's under enormous pressure to give interviews, Professor Barry Schoub, who, when I looked at his CV, astonishingly, became a professor of virology at the age of 33. I almost feel, Barry, you must have had your bar mitzvah by the time you really were a professor.
I was still in short pants, actually.
And it's now, of course, the chairperson of the Ministerial Advisory Committee on COVID-19 vaccines. And thank you very much for doing this. I wonder if I could start by asking you not so much about vaccines to start with, but just because you're, one of our most distinguished virologists, just to talk a little bit about the second wave. I mean, is it possible that at least we will get to the top of this wave and it will come down to some acceptable levels within the next month or two? Or are we going to go the way of other developed world where they seem to have battled to keep it under control?
Yeah, good morning. Thanks very much, Dennis, for having me. Yes, I think that the epidemiological picture of COVID is that it does come in waves. It comes in waves because what happens is that the population is susceptible. The virus spreads, and as it spreads, then more and more people get infected and become immune. And then, of course, the virus will go down again. And then in time, of course, there's a buildup of people that become susceptible. And again, you have the repetition of it. What does seem to be a little bit kind of concerning is that the second and in some cases subsequent waves, third waves, are appearing to be more severe. Now, as you know, there is a variant of the virus that has now appeared. Is it due to that, or is it due to human behavior? As you know, our second wave started with the, I think what triggered it was that so-called super spreading event, that the rage functions. I'm not saying that was the entire cause of it, but that seemed to be a trigger. And now maybe the variant is perpetuating that epidemic, but it will come down. It'll come down for a while, and then of course it will go back up again as susceptibles build up. Until we have a vaccine, then of course the vaccine will contribute to controlling the epidemic.
So I won't come back to the vaccine, obviously, but I just wanted to ask on this. I suppose, I'm trying to represent the ordinary person who obviously is understandably anxious and quizzical about what's going on. Now, if you take the idea that this variant may well be more transmissible, then, and of course you can correct me, but that's the assumption that some people seem to be working on. The question is, were we then too slow to come to level 3? In other words, we have this press conference where Professor Karim and others tell us about the variant, maybe more transmissible, maybe more dangerous, but we waited almost 2 more weeks before we introduced the lockdown level 3. Wouldn't it have been better, some of my medical friends tell me, if we'd actually behaved more decisively earlier on?
Yeah. No, that's a very controversial question, because some of my colleagues, in fact, feel that lockdown doesn't help. What lockdown does is it postpones the epidemic. The one advantage of lockdown is that it does give the healthcare system a bit of a break and time to kind of build up resources. But in terms of the epidemic, it actually postpones it rather than get rid of it or stop or decreasing it. So, the problem, it's always a balancing act. It's a balancing act between what is the cost of all these restrictions, including lockdown, versus the benefit. And you have to kind of weigh up that cost-benefit analysis. And lockdown comes with a lot of cost, economic cost particularly. So I think they were looking at finding some restrictions which wouldn't have economic consequences, but still have public health advantages. And that's why there are a lot of discrepancies.
But we now are faced with an extraordinary situation of hospitals being absolutely overflowing.
Yeah, I know. It's very, very upsetting. It's very disquieting. And it's not only here, it's around the world. This is a very severe disease, completely new. It's new to science, it's new to medicine, it's new to public health. And one of the problems, as you say, is making hospital provisions. So I feel desperately sorry for healthcare workers in the front line. My son's one of them.
Yeah, well, exactly. Well, what I wanted to ask in relation to that is, if that is so, then that does mean, as I understand it, that our only really long-term solution to bring this under some form of control is the vaccine. Would I be right on that?
Absolutely correct. But can I stress one word you said? Long-term.
Yes. Yes.
Long-term.
Just tell me, let's assume tomorrow morning that we could wave a magic wand and your 67% of your population that you spoke about in your presentation had the vaccine. What would that mean? What would that mean for our lives? Would we still be wearing masks? Would we still be having very cautious restrictions? What would happen then?
I think what we're really aiming for is to get what you call, you probably heard the term herd immunity or community immunity. That's a threshold. It's the threshold of the percentage of individuals who are immune. Once that happens, the virus, to put it colloquially, doesn't have enough hosts to go to propagate itself, and therefore the epidemic comes under control. It differs for different viruses. We define it what's called a R number, reproductive number. So some viruses, you look at measles, is of course a very high reproductive number, and COVID is much less, and influenza even less than that. So we need to try and get to that threshold, mainly with vaccines, but also with the non-pharmaceutical interventions as well.
Which is what we're supposed to be doing at the moment. I wanted to ask just before, because my next question will be in vaccines, but before I get there, I was just listening today on the radio. It appeared to be that there was some research done. I don't know how reliable, but let me just offer it to you, that the amount of people who prepared to take a vaccine in South Africa on the study seems to have reduced. People, 53% on this particular study. Is that because we've actually not been good enough in our public education until now? Have we not really told people? Have we failed in that regard? This is nothing your responsibility, but I'm just talking as a society.
Yeah. Dennis, you hit the nail on the head. Absolutely. Absolutely. We have failed in that. Unfortunately, we're not good communicators. We've got to admit we're not good communicators. And people are nervous. They're fearful. They're afraid. This is a new vaccine. There are new ways of making the vaccines made at breakneck speed. So people are asking questions justifiably. What we got to do is come and say, look, these vaccines undergo a very rigorous evaluation by an independent monitoring board at the trial stage, at the licensing stage, and after the licensing stage as well, post-licensing surveillance. So all of this is trying to show.
So let me ask you this. If, for example, as I understand it, correct me if I'm wrong, my understanding on listening to the webinar on Sunday was that the plan, if I could put it that way, is to get the vaccines up and running, to inoculate or have people have the vaccine to the extent of 67% of the population, roughly 40 million, I would have thought. And by when? And the idea was to do it by the end of 2021.
Yeah, ideally, that's the aim.
Ideally,
that's the aim.
Well,
ideally.
now, so let me ask you, so the criticism, as you know, because you've been, I don't need to tell you, but people want me to ask this. So let me ask you, what's the plan to get us to a position of whereby 60, that's 40 million people. That's an astonishing enterprise.
Correct.
And get it. So if you listen carefully to what had been said, I understand that we may well get some vaccines through the COVAX facility, and hopefully that will go to the people most in need, which is our frontline workers, your son and the million, as I understand, of people more, frontline workers, which is great. But the question is, what then? How do we? I mean, what's the plan to get us to the 67%?
Yeah, can I just correct something? The COVAX is in a way a fallback position. That's going to come a bit later in the year. Probably.
All right, sorry. Yeah. When will the COVAX come? So let me clear that.
Well, we rely on COVAX to tell us. Now, what they've told us is that it's going to be either, and this is just relaying what they tell us, either end of the first quarter or towards the second quarter. I think the president hedged, maybe took a more conservative view and said second quarter. But we rely on them because they're doing the purchasing of the vaccine. And that's when that's going to come.
Who does the purchasing? COVAX.
COVAX, correct, yeah. Yeah, it's a
consortium. So we're in the hands of COVAX. And how much do we know how much we will get out from COVAX?
Well, what we the kind of down payment that is basically calculated on 10% of our population. So that's what, about 5 million or so, 5.9 million.
And will that come in?
It's double that number of doses, because it's
yes,
2 doses.
Yes. Although I come back, I'm going to ask you about the British system now, where they're giving people one. But if I can just park that for a moment. Sure. But could I ask you on that? Will that come in stages, or will we get the whole caboodle at the same time? Let's say end of the first quarter, beginning of the second quarter.
From COVAX, I think COVAX will come as one tranche. COVAX will be one tranche. But what we're bilaterally negotiating, that's going to come in tranches.
All right. So now, so the criticism has been that other countries have managed to acquire, we haven't.
Yeah.
Correct. And it does appear from your advisory, or not your advisory, but the advisories that were published just the other day on the Department of Health website, that the negotiations began in September. Why is it taking so long to, in fact, get to a position where we still don't know? You can't tell me that, in fact, if I'm reading you correctly, if we are not lucky, but if for example, at least it happens quicker or as quickly as they promise, we may get 10 million doses, 6 million doses, sorry, 10% of the population by end of first quarter, second quarter. And I'll come back to how you propose to allocate that in a moment. But beyond that, you can't tell me at this stage, not your fault, but you can't tell me, or the country, that in fact, from that moment until the end of the year, we're going to get, let's say, the additional 30 million doses that we require to get you to your herd. So why? What is holding that process up?
Yeah, it's a long story, and I'll try and compress it into a few seconds.
I have time. You carry on.
As much as I can. What's happened is that there was a vaccine grab, and I think that's the best word, grab, by the high-income countries. Because basically, irrespective of what you hear from so-called eminent scientists, they are wrong. They are dead wrong. There is an upfront payment which is required for advanced market commitment. That came to about, for the 40 million doses, about 2.4 billion rand. And the problem was, of course, we don't know which, at that stage, early in the year, which vaccines were going to be effective, which vaccines were going to be safe. Certainly the trial data was very good, but there's no assurance of that, and no assurance what would be applicable to South Africa, like storage and distribution and so on and so forth. So, and I must stress, I'm not a spokesman for the Department of Health. I don't
understand that. No, understand that.
I don't receive a cent from them. This is voluntary. But
I understand that.
Yeah, there is a financial commitment. There's a severe financial, which they didn't feel that they could take. But you know, really, where we could have, where personally, if I may say, where I think we did go wrong, is I think you know we had 2 trials of vaccines in the country, as you may. In fact, there were 4 trials in the country.
Yeah.
Now the negotiations between the vaccine manufacturer and the principal investigator got nothing to do with the government at all. They negotiate and they sign a contract. Now, in that contract is all the kind of legalese, which I don't know much about, and you obviously know a tremendous amount. Why then? Because they were exploiting South Africa's condition. You know, they knock on the door and say, Mr. Principal Investigator, I'd like to do a trial because we need the trial data to register our product so we can sell our product. So we were helping them doing the trial using our facilities. We could very easily at that stage say, look, can we have a commitment, a signed commitment, not a vague thing that we would like to kind of supply, but a commitment as part of the contract to supply the country. And we didn't do that. And we could have done that.
But that's a monumental failure, because the truth about it is we had leverage. We may still have leverage, surely. Because let me try to track this and make sense of it. You can correct me if I'm wrong on any of my assumptions. But when I listened to Dr. Pillay in particular, because on his presentation, he took us through, it was him, not you, correct me if I'm wrong, but I think I'm right, that he took us through the various vaccines that are available on the market at the moment. So let's leave aside the Russian one. that I'm not entirely sure anybody would want to take, but that's another matter. And the Chinese one, where Dr. Pillay says we can't get the stage 3 results, so we got to take that off the table. He then said there were 4. Moderna, which appeared to be not particularly interested in giving vaccines to South Africa, that reflects on them. It's got nothing to do with the government, and it's a shame on them that they are prepared to send developing countries down the toilet, but that's Moderna. Then it's Pfizer, Johnson & Johnson, and AstraZeneca. Practically speaking, would I be right that given the refrigeration requirements for the Pfizer vaccine, that the most viable vaccines for South Africa are the AstraZeneca and possibly Johnson & Johnson, because on Johnson & Johnson we don't even know because they haven't finished their stage 3 trials. Correct. So am I right in saying, really practically, there are, if you could call it, 1.5 options open at the moment: AstraZeneca and the possibility of Johnson & Johnson?
Not quite. It's a little bit more complicated than that.
Why?
Unfortunately, sorry to make it a bit more complicated.
No, that's fine. I want people to understand, which is why I'm putting this to you. Yeah.
Okay. Obviously, we would like vaccine to have come right in an assurance when they were doing the trials. That would have been first prize. Second prize, to have vaccines for our healthcare workers, particularly now. So yes. Those. But the third prize, and I know it's a lower down prize, it does give us a bit of breathing space to kind of see which actually are the best vaccines. And the one which is not totally off the table, we don't want to put totally off the table the Russian vaccine, which is being rolled out in some countries. Now, we talk about middle incomes rolling out. Argentina's got it. Egypt's got the Chinese vaccine. There are a number, I've got a list here, a number of these middle income are using Russian and Chinese vaccine. And the Chinese vaccine's got a lot of merit to it. I'm not saying that at this stage we just don't have the data, but theoretically it's got a lot of merit to it.
Okay, but I'm talking practically.
Practically speaking, Pfizer is not off the table either. It's got.
But can you seriously advance the proposition that if we require the refrigeration, and again, correct me if I'm wrong, that South Africa could actually roll out millions of doses of Pfizer? Do we have the facility to do that?
We have the facility in our big urban centers for our healthcare workers. In fact, Pfizer.
Okay. No, I accept that. Yeah. So for the healthcare workers, I accept that we may be able, and Pfizer seem to be offering. Am I right that they seem to be?
Yes.
And how far are we with that? Let me just start asking you on that.
I would love to know, but unfortunately, as Department of Health, there are non-disclosure.
But if you don't, Professor, if you don't know, Barry, if you don't know, I mean, pardon me while I slit my wrists. I mean, how are we supposed to know? You, the man.
No, Dennis. Can I just say something? I'm not a lawyer. You are. You know what a non-disclosure agreement is. They signed a non-disclosure agreement. I didn't sign a non-disclosure.
Yes, I appreciate it. Yeah.
Wouldn't I be locked up if I disclosed?
No, I'm not asking you to disclose. I'm merely saying that I mean, non-disclosure agreements are agreements. I accept that. But I mean, to some extent, we know. The one thing we know is that at this stage, I appreciate that we might, the Russian and the Chinese, although I have to be honest, as an ordinary non-scientist, you can persuade me long and hard before I find the Russian vaccine.
I'll have to persuade you if it does come about.
Yeah, I know. You and I will have a conversation about that before I take that. But be that as it may, at this stage, practically speaking, the 3 that are most viable for South Africa are Pfizer, Johnson & Johnson, AstraZeneca. Correct. So we don't have non-disclosure agreements with that because we know that those must be the 3. You don't have to tell me, we can deduce that from evidence. I suppose the point is, if Pfizer and Pfizer are prepared to offer us at a reasonable rate vaccine, what you're telling me is we could, even with the refrigeration requirements, get our health workers in the urban areas vaccinated. Would that be right?
In the major urban areas, yeah.
But would I be right in a more widespread vaccine would require one of the other sources? Correct.
But then even then, AstraZeneca, for example, has got a 62% efficiency. That we still have to go into. It's not great. It's not great.
But why are the Brits using it then?
I don't know why it's been licensed. I don't know. I can't
They have. I mean,
I'll tell you why. I'll tell you why. Yeah. Because to reach herd immunity, it's the vaccine efficiency multiplied by the coverage to get to herd immunity. They've got much better coverage than we have. Now, if they've got 80, 90% coverage, even if it's a 60% vaccine, they will get to that herd immunity.
So, but then logic would tell me that if we could get enough doses from AstraZeneca, we could do the same thing.
Provided we get that kind of coverage, correct. I'm not.
That means
I'm not saying it's off the table by any means. I'm just saying these are factors which come into consideration in the planning stage.
But so let me go back to this. I mean, if I could just AstraZeneca. Well, there's something else which is interesting. Oxford University expert was used in the AstraZeneca vaccine, as I understand it.
Correct.
I understand that AstraZeneca had not really had much of a record for vaccines prior to Oxford. That's why they needed Oxford.
For the support.
Oxford University came out and said they regarded the vaccine as a public good, which they should have.
Yeah.
The question I suppose I'm asking is, what's their role in this now? I mean, would they not have some ability to pressurize AstraZeneca to give developing countries a significant supply of the vaccine as they produce it, precisely because they regard it as a public good?
You're absolutely correct. One would expect that, but but look what's happening. They've kind of asked the Serum Institute of India to do the bulk of them distribution and manufacturing and so on.
Yeah.
And the Indian authority, I don't know at what level, have put really an embargo that the Indian population, a certain percentage, has to be immunized first before they let the vaccine out. And
the other thing I suppose I wanted to ask you was, I mean, there are rumors, and you don't have to, if you don't want to comment on them, that's fine, but there are rumors that AstraZeneca are trying to extract a very significant price from us, higher than the $3 to $4 that get floated around in the New York Times and the Guardian.
Well, I can't comment. I don't know. I've never heard that. This is the first time I hear that.
Okay,
I don't know.
Right. But I mean, the question. So let me ask you about Johnson & Johnson. There's a lot of confusion about this, and you might be able to help me here. I'm not blaming the president, but at some particular point in time, he did raise in one of his speeches the idea that there was some deal with Johnson & Johnson for 300 million doses to be produced in Port Elizabeth and East London plants or something of that kind.
Yeah, correct.
Now, there's confusion about precisely what that means. Does that mean that we have the capacity to make the vaccine, or is it that we would do like the end part of the actual production chain? What can we do in South Africa?
No, it's the end part. They get the bulk and then they distribute it. It's not, I mean, it goes to a very sterile plant and filling lines and so on, into the vials and to the pre-filled syringes. So they are doing the end part, not the manufacturing, but the distribution essentially.
So how would it come to South Africa? Just excuse my ignorance. Does it come in sort of 44-gallon drums? I mean, how does it?
I guess it comes a bit more than that. It has to come in a cold chain. It's got to be refrigerated, etc. No, it comes special containers.
But I am right, therefore, in saying that at the very least, there will be plants in South Africa that will do the end part of the production line.
Correct.
Now, surely that must mean that we've got some leverage over them. You can't.
Absolutely. I couldn't agree with you more.
So what are we doing about that?
Well,
I have to talk to Johnson & Johnson about that. I mean,
you have to talk to Aspen as well. I mean,
I am going to be talking to Aspen, I assure you.
I'd like the comeback. I'd like to know it.
Well, it'll be recorded because we're going to actually have a recording. We're going to have a discussion with them precisely. But where are we on that? I mean, sorry, I interrupted you.
No, sorry, Dennis. I think there are two things. You said that one is I think your words are a monumental issue, which is the trials. At that stage, you could have got a commitment, and we didn't. It should have been a commitment as part of the arrangement. We didn't do that. We could have had Johnson & Johnson, we could have had AstraZeneca, and to some extent also Pfizer, because they were trialed here. The second one, of course, as you said, Johnson & Johnson in Port Elizabeth. They are distributing and bottling, which is a significant part of it. Why is there no assurance? And I say assurance must be a legal commitment, not just a very nice, there's a very nice letter, I've got a copy of it here, but that letter means nothing in legal terms, correct me if I'm wrong. It's got to be a signed contract.
Yeah.
Why was that not done? So it's interesting. This coronavirus epidemic. People are fearful. People are worried. It brings out three things. The one thing is conspiracy theories. The second thing is miracle drugs, and we had hydroxychloroquine, and a vaccine is a miracle drug. People are expecting the vaccine comes, that's the end of the epidemic immediately. And the third thing is that people blame. There's a blame. So now it's the government is the whipping boy, and our Mac is the whipping boy. And that's what the societal stress brings out in people.
But what the vaccine does do, again, correct me if I'm wrong, that there are millions of South Africans, like myself, I'm a diabetic. There are millions of South Africans diabetic, have other comorbidities, young and old.
Yeah.
We wake up in the morning in a real sense of stress, because if we do this, we just don't know. I mean, it's true that many of us survive, and some of us even get mild symptoms, but others don't. And many of our loved ones, people listening to this discussion, have died. And so would I be right in saying, at least if we have a vaccine, people may still get ill, but less people will die?
Correct. Absolutely right. Yes, for sure.
So we are playing with life and death here. I mean, this is an unbelievable challenge. So I suppose right. So the question, I mean, could I just ask you, your role is just to advise, is that right? Is it to advise about which vaccines are appropriate, or what is your role actually in this grand scheme of things?
Okay. As the name is, the ministerial.
I should have asked you earlier. I'm sorry. Yeah.
No. It's a ministerial advisory committee to the minister, not to the public, but to the minister.
Right. Yes.
We do it by advisories. Initially, those advisories were actually confidential, but we all in the MAC, both the other MAC, Slim Karim's MAC and ours, we pressurized to go out into the open, and we to be public. And we pressurized. I don't know why there was a delay. I can't answer for them. The other MAC had theirs published a lot earlier than ours. And every meeting that came up, we said, please publish our advisories. Only now they've done that. So our advisories also do go out to the public. But our role is to advise on which vaccines, budgetary issues. We've got somebody from Treasury, ethical issues. We've got the director of the Steve Biko Institute. And what are the other work streams? Budgetary issues, but obviously not the nitty-gritty of the rollout. That's really the Department of Health works that out.
And would that include distribution questions? Would that be theirs, not yours?
Look, ours would be in broad terms. We would say, right, we need distribution right down, and then ask the Department of Health to report to us how they're going to do it. But the actually working out of those is their responsibility.
But would you not be anxious about the fact that even now we should have a plan, which if we got those 6 million doses, which means that you cover significantly more than your health workers, because the cohort seemed to be just over 1 million, 1.2 million, as I read in the. There's another 4.8 available for older people or other frontline workers, and then you hopefully, of course, you've got to get more in order to get your 67%. Would I be right in saying that we should really have a concrete plan of distribution now, which could be, the button could be pressed tomorrow morning if we got the vaccine?
Well, we did on Sunday night. I think there were 22, 24 slides that Anban Pillay presented with details.
And but I'm not sure what that meant. To be honest, with respect, I'm not sure what that meant. I mean, how do you get the vaccine to rural areas? I mean, are we going to use the private sector? Some people suggest that Coca-Cola and SAB have the best systems in the world. There's a sense of like, are we contracting with them? Have they been spoken to? Is there a plan that actually gets the vaccine to the various clinics and facilities, which would be the administrators? Do you know that? Do we not know that?
Well, we do, because some of it is piggybacked on the infant and child immunization. So some of those challenges, getting vaccine to those places under cold chain, that is long known. It goes with the child vaccines. Obviously, there's an additional thing because we're talking now about adult vaccination.
We're talking 40 million people.
Yeah. So some of it is the workplace. Some I don't have all the. I'm just also going for.
Well, all I'm asking is, I saw what Dr. Pillay said, and that told me that things would be done in clinics, etc. It did not tell me how the vaccine was going to get there. It didn't tell me whether that was the most appropriate place for the vaccine. I'm simply asking.
Yeah.
Surely at this stage, we can't have the same situation that you've just acknowledged quite graciously, that the government should have put pressure on these others. We should, tomorrow morning, be able to say, yeah, that's their plan entirely. They, from A to Z, they know how to distribute 40 million.
Well, I think they do. If somebody would go to
They're
the
not telling us.
they had what, half an hour or so.
Oh, come on. I mean,
look,
all right,
well,
okay. Well, maybe you could tell them that, maybe you could tell them when you meet them next time. That they could
honestly, Dennis, they had what? How long? He spoke for about, what, 20 minutes? Yeah, 24 slides.
Yeah.
You want him to go into detail?
No, I would have liked him to say, okay. I would have liked him to say, and we're going to be using the private sector in the following ways because they're really important. To which raises a further question.
I need to correct something for me. Sorry to interrupt.
Yes, of course you can.
Contractual arrangement between the vaccine manufacturer and the principal investigator. The principal investigator has a responsibility, not the government.
Yes, but once we knew, as we did from September, that or maybe we should have done earlier, that we needed the vaccines, and once we had AstraZeneca trials, and once we knew Johnson & Johnson were coming here, government could have put pressure on them.
They could have put pressure, but the responsibility, they signed the contract. They at that stage, they said, look, we will do the trial for you, so you can register your material using our resources, provided that on the condition that you allocate a certain number of vaccines.
We're in agreement. We're in agreement. And as much as I'd like to debate that further with you, I have other issues. So here, I want to ask you this. No, I'm very grateful for your time. Let me ask you this. Dr. Pillay said it all had to be procured through national government. And there is some anxiety as to why the medical aid schemes, etc., can't, in fact, access vaccine. Why are they being prohibited from doing so?
I'm not sure they are being prohibited. I think.
Are they not? I don't know. Just clarify for me.
No, the way I understand it, and again, this is something which maybe Adrian Gore and that team can answer much better than I can. But the way that I understand, because it's a little bit out of our purview, but the way I understand it is that there's a central procurement, because that's the body that can bulk buy a large amount of vaccine, and that'll have to be the government, through the procurement of the government, and then in private access via medical schemes or industry, mines, whatever it is, will access from that pool. That's the way it's going. That's
why would the medical aid schemes, if they got together themselves and said, we can actually get a deal from one of the manufacturers, from the pharmaceutical manufacturers, we can do a deal for all of our members. And indeed, if government said, yes, you can, but we got a certain conditions on that, then if you can access them at a better price than we can, then fine and well, provided that you do the following for the public sector. Why can't we have a private-public partnership?
I really can't answer that question. I mean, I think that I think one of the business guys is the best to answer that. I presume that they found that to be the most effective way of procuring vaccine, just in terms of the bulk of the amount, because the private sector would only have relatively small amounts to buy.
All right. Well, yes and no. I mean, medical aids are quite large. Anyway, can I ask you this?
Relatively.
Yeah, relatively. Could I ask you, one of the anxieties, I noticed an article in The Guardian just the other day, or might have been yesterday, these things happen so quickly, the anxiety about the fact that this new variant may well actually cause some problems for the vaccine.
Yeah.
Do you know anything about that so far?
There is a lot of anxiety. Let me put it that way, because the studies are very new. This has really only been detected maybe a week or two ago, quite recently. And what they have determined, the early stages, the very preliminary stages, were reassuring. But now in greater depth, when they're looking at the molecular structure of the virus, how it interacts with neutralizing, it's obviously very technical. There are some alarm bells which are now being rung. Now, it's not to say, I must clarify, it's not to say that the vaccine at this stage, that we've got concrete evidence that it won't work, but there's a lot of anxiety, there's a lot of worry, and this is an ongoing program, both looking at from a laboratory side, from the molecular side, and also patients. We need to look at individuals that had the previous strain, the individuals that had the low, and see, are there breakthrough infections from people that have been vaccinated? So this is an ongoing study.
And how long will it be? I mean, people want to know this. Presumably, is it something that we'll be able to know about in a relatively short period of time, that the existing vaccines are good enough for the variant?
We all are anxious to know that as soon as possible. How long those investigations will take, it's again, it's the molecular virologists who are doing that, and I presume we'll have some good indication, certainly in the next couple of weeks. My understanding is going to be some announcement, probably I think within a week, of where we are. Might not be the definitive statement, but how far those researchers got to. But that's
because
the one thing. Question.
Yeah. Because the one thing, and I mean, you were at the forefront of this field. I mean, the one thing we do have in South Africa are absolutely world-class virologists.
Yeah.
Yeah. So we should actually. So then, can I just ask you, Professor Barry? Can I just ask you? I mean, just looking at it from the point of view, how realistic is your plan to have 67% of the population vaccinated by the end of the year?
I wish I could give you an answer, but as long as you don't hold me to it.
I'm not holding to anything. I just want to get a sense.
I think it can be done, and I think it should be done, but it is a monumental challenge. If the Department of Health can meet that challenge, we'll have to see. They certainly met the challenge of HIV treatment, become a world leader in HIV treatment. There's also human disease and as well as health. They might come up to that challenge. I do hope they will come up to that challenge, and we'll have to. I hope they will look at it in the same way as they looked at the HIV challenge.
Barry, thank you very much. I've run out of time. I could spend another hour and a half with you. I'm sure you've got other things to do.
It's a pity.
It is cast
a lot I wanted to say, which I didn't.
Yeah, we've got a lot of light on the subject. May I just abuse my position by saying it'd be nice to have you back again in a few months' time so we can talk further about this. But I'm grateful for your time and for your work. Thank you very much.
Thank you very much. Love to come back again. Thank you.
Pleasure.